Good afternoon and welcome to Open Classroom. I'm Janet Gillow, Director of Professional Development for the Brown School, joined by my co-host Lee Colliker, Director of Career Services here at the Brown School. And we have a very exciting program for you today. I do want to take a minute before introducing today's speaker to talk about an initiative and sort of our response to things going on in the world right now, some programming that we have coming up. Undeniably, this is a unique moment in the racial history of our country. A system that has been unequal, has been really strained, so much pain and so much will to change right now. And the Brown School is committed to creating spaces for conversation around this. As part of this Open Classroom series, we sort of have a series within a series that's emerging called COVID-19 and Race. And these programs examine racial disparities and inequities. Recordings of the first two programs are already up on our website. And if you did not catch them and you're interested in the topic, I strongly encourage you to. Just speaking personally, the second one I just found really, really affecting. It made me cry. And so if you are interested in leaning into the conversation, encourage you to check that out. But we also have 3 upcoming programs that you can participate in live in this series. Part 3 is this Thursday at 10 a.m. and it's specifically on the topic of race and political action and advocacy. The part 4 is going to be on the morning of Tuesday, June 23rd. We'll be talking about the experience of the Native American community. And then part 5 is the afternoon of Tuesday, June 30th, when we'll be talking about issues affecting the Latinx community. So I'm just offering that justice, mercy, and equity are not pie, and more for one is not less for others, and that it's an important conversation for all of us to be participating in examining what a more equal and compassionate country would look like for us. Which I hope is a good segue into today's conversation, which will be led by Dr. Jessica Levy. She's Associate Professor of the Practice at the Brown School. Her research focuses on the intersection between gender, poverty, and global maternal and child health. She aims to identify culturally appropriate interventions that promote gender equality and improve reproductive health and development outcomes. She's worked in underserved communities here in the U.S., but also in Latin America, Sub-Saharan Africa, and the Middle East. In addition to being a professor of practice at the Brown School, she's a faculty scholar at the Institute for Public Health and a member of the Brown School's Global Advisory Committee. Here today to talk to us about COVID-19 fallouts, preventing unintentional aftershocks on gender equality, Dr. Jessica Levy, please welcome her.
Thank you, Janet. I am going to attempt to share my screen here. And start this. Do you see the web or the, yeah?
Yeah, see it, that's great.
Okay, great. Hello everyone. It's a little awkward looking at my screen and not being able to see all of your faces, but I am really happy to be here. And as my colleague, Daryl Hudson always does, I'm going to start with a thank you, knowing that there's just so much, as Janet said, going on in our world right now. And if you're like me, you're likely very distracted and consumed by it. And so I appreciate you taking the time to be here with us today and to talk about this topic that is very related to what's going on. Certainly gender intersects with race and class and age and all of these things, and we're going to be talking about that in a bit here. I did want to also give you my contact information from the beginning. This is such a huge topic, and it was really hard to come up with this lecture because I didn't know which angle to take and which parts to include. So I would love to continue the conversation and answer questions if you have them. You're more than welcome to email me. My email is there. And I also, as Janet mentioned, I am an associate professor of practice, which means that rather than doing research, I actually practice. I'm in the field giving technical assistance to large donor organizations like the Gates Foundation, governments, ministries of health all over around the world, nonprofit organizations like Save the Children or multilateral organizations like UNICEF. And I do a lot of that work as an associate at a group called IRIS. And we have, I've given you our Twitter account there if you want to follow us. And I also run a nonprofit organization. We do health and development work in Uganda, Malawi, and Brazil. And I've given that information there. So hopefully we can continue the conversation through all of these avenues. I also wanted to, before I get into things, say that though this is focused on gender, there are many populations at risk, and the ones who are most at risk are those who have inadequate access to social services or may not have the political influence to make change, who have limited or no access to technologies. Obviously, we've heard a lot about those who have comorbidities, which is why, partly why we're seeing a lot of variance in some of the health outcomes we're seeing. It's also affecting people who rely heavily on the informal economy and who are losing their jobs because they don't have stable income and the ability to keep their work. Also, in terms of mental health, it affects people who may have limited capacity or opportunity to cope and adapt to what's going on, which lately I feel like is many of us. And then, of course, people who occupy areas that are prone to shocks, whether those be environmental shocks or conflict shocks. And when you put all these together, obviously, many people don't just experience one of these things. So when we're talking about women and gender, we're also talking about women and gender who happen to be older or who happen to be younger, who may have disabilities or may be a part of the indigenous population, or refugees or migrants, or of a racial or ethnic minority. So when you combine these different identities, what I'm going to be talking about today, the impacts are actually amplified. So I want to keep that in mind as we have this conversation. That said, we have had a lot of information since the beginning of this COVID pandemic around the varied impacts of COVID on sex and gender. In many settings, and again, I you know, as I've said before, most of my work is around the world. So this lecture today is going to be globally focused, but I'll also pull in a lot of the effects that are happening here domestically. But that said, in many settings all over the world, we're seeing that women appear to be slightly more diagnosed with COVID, though we don't know if that's because of differentials in data collection or so on. So we'll talk a little bit about that. But at the same time, we're seeing a consistent pattern of higher death rates among men. So that begs a question. It begs a few questions, in fact. Are men or women more likely to contract COVID? Some people are saying that, you know, COVID is an equal opportunity pandemic. Well, we know that's not true now. Once infected, are men more likely to die? And if so, why? What are factors that may be driving these differences? And what are the long-term impacts that influence quality of life, including health and well-being? So not just about mortality. To answer some of these questions, I have a few objectives for today. This is our agenda, if you will. And I am going to try and keep it semi-short so that we can have a good conversation at the end. So the first is, why are gender norms important when we're talking about COVID? Often when you hear in the media, you hear sex or gender used more loosely. So we're going to talk a little bit about that. We're also going to talk about what are the actual differences and impacts of COVID-19. And I want to look at that in terms of direct influences, but also some of these more indirect influences. And I'll also be looking at those impacts globally and domestically. What are the potential impacts on gender equality? So what are some of these longer term impacts? And then finally, where do we go from here? And I have this kind of trigger warning symbol here because when we're talking about these things, especially in the global South, and when I say global South, I mean in low and middle income countries, it can be triggering because it is really, a lot of the things that are going on are really difficult to hear. So I just want to put that out there for people who aren't used to hearing about these things. So going back to the data, this is comes from a big study done by Global Health 50/50. And again, what you see here, and it is a little bit difficult to see on my screen, is that across the world, and this again is, we've been seeing this from the first reports of the virus, that that in fact, it's not totally clear who is actually being contracting the virus or being tested positive. But what we are seeing is an overall or an overarching difference in death. And so, you know, men are dying more than women. And so, again, this, you know, it's a bit of a conundrum because unfortunately, a lot of countries aren't collecting data or national data that is disaggregated by sex. But from the data that we do have, this is what we're seeing. We're seeing men are dying more, but that it depends on the context as to who is actually getting the disease. And so one might say that, you know, that might have to do with sex itself, that somehow, you know, are men weaker? Are men biologically more prone to getting this or being affected by this disease? But it doesn't explain it all. And so one of the first things I want to do is really is give a bit of background on the difference when we talk about sex versus gender and gender norms and versus this gender system that we live in. Because often people don't understand that there is a difference when we talk about these things. So when we're talking about sex, we're actually talking about a biological construct that defines males and females according to their physical characteristics and reproductive capabilities. So often when you look at data and research, data are disaggregated by sex. And so, you know, sex is usually assigned to a baby when that baby is born, whether or not they have a penis or a vagina. And but we know chromosomally that that may not be the case, but in some ways it's still a cultural construct, and that's how it's defined. But the point is, they're not always mutually exclusive, but gender and sex are not synonymous. We're not talking about the same thing. And indeed, when we're thinking about sex, there is some evidence to say that COVID has varied effects based on these sexual hormones and chromosomes. So in fact, there is some research that shows that sex hormones play a role in determining how well human bodies can fight disease. So estrogen, which is often found in what we would consider to be women, estrogen amps up the immune system, while androgens, which are often found in people who identify as male, like testosterone, progesterone, it tends to suppress your immune system. So one thought is that because of your sex hormones, you may be more or less likely to have immunity to the virus, even if you get it. Another theory is that sex hormones may play a role themselves. So as many of you know, the majority of people who identify as women have an XX chromosome. And X chromosomes have 60 genes associated with immune function. Whereas the XY chromosome, obviously men have that X chromosome itself, but they don't have as much immune protection. So these are some theories around why sex itself might actually have some protective attributes when it comes to mortality and COVID, but it's not that simple, because even when we look at things like influenza or you know, the common flu, we find that in fact, by having this higher immune response, it can be harmful instead of protective, because having too much of an immune response can increase complications with acute respiratory distress syndrome, so lungs can fill with air. And in fact, we're also finding that when those hormones are high, for example, during reproductive age, women can actually do worse than better. So it's very complicated, and we're still trying to work it out. It also doesn't explain everything. And that's where we come to gender norms. So when I say gender norms, I'm talking about these social constructs that define what is expected of a woman and a man in a given group or society. So gender norms shape acceptable and appropriate and obligatory actions for women and men to the point that they become a profound part of our sense of self. So when we're talking about gender norms, we're talking about norms that are embedded in our institutions, but also in our minds, how we identify. So they play a role in shaping what is expected of us, how men and women are valued by society, what are the roles and expectations around us, what are our beliefs, our power associated with being male, female, masculine, feminine. I teach a whole course on this alone, so I'm not going to get too deeply into it, but the point being is that when we're talking about gender norms, we're not necessarily talking about identity itself. So, often when I give this, when I give these lectures, I like to begin by saying that, at the Brown School and certainly in many social circles, we talk about and we're trying to progress the idea that gender is a spectrum and that it is a social construct that can change over time and depends on the situation in which you're in. But because of gender norms, in fact, in many areas where I work, it's very binary. And if you don't fit those buckets of male or female, you can actually, well, certainly here in the United States as well, be harmed or even killed. And so when we're talking about gender as an identity, often we're talking about things that go along that spectrum, whether along the gender spectrum. And it's a deeply held personal sense of oneself, whether it be transgender, non-binary, et cetera, et cetera. And it's also, it's not structurally imposed on you. It's something that people individually embrace. But when I'm talking about gender norms, I'm talking about an actual socio-structural system. And by that, I mean, what power, what resources, what roles are given to people who fit in those buckets of being male and masculine and female and feminine. And how do those social norms actually affect our behavior? And we're going to talk about how that influences health behavior. And so that's what we're going to be talking about today. So what do gender norms have to do with COVID? Well, again, I'm a visual person, and I'm just gonna show this here. So we're born with certain features. We have hormones, genitalia, we're assigned a sex, and we begin to move through this gender system, right? So that system may be what is expected of us within our homes, what's expected and valued within our communities, our institutions, our structures and powers and policies, excuse me. We begin to move through that system and begin to be shaped. And we're also then shaped by other identities that we hold. So whether it be race or class, our age, our abilities, these things are all structuring our gender. They're all becoming they're molding us into the gender that we see and see ourselves as, but also how the rest of the world sees us. And then because of that, it influences our pathways to health. So it influences how we're exposed to disease, whether or not we actually get treated for different diseases or tested for that matter, how we behave, whether or not we can access different levels of care, how the exposure to a disease actually impacts our bodies, and whether or not we are impacted more more heavily or not. So these gendered pathways actually result in health inequities and health outcomes. I feel like this is a lot. It's hard to keep talking and not knowing if people are responding, but I'm guessing, Janet, since you're not saying anything, people are going with it. So
people are going with it, and we're starting to get questions. Just encourage people to throw your questions into the chat, and we'll get to them at the end. No, it's good. I'm with you, and so are they.
Okay, great. Like I said, I do a whole class on those 4 slides alone. So, so let's get back into then. So if we know that sex has something to do with, and again, sex meaning those biological hormone features, has something to do with the outcomes in COVID, but not everything, then we have to ask ourselves, okay, what is it about our gender norms that actually influence whether or not we're exposed to COVID, get tested for COVID, get treated for COVID, and whether or not we die from it? So let's start with masculinity, right? So we have these ideas of masculinity within the United States and all over the world. And these ideas of masculinity, just like ideas of femininity, influence our behaviors. So if we go back to what one of the, if we go back to some of the reasons that people die from COVID or are more likely to die from COVID, one of those reasons would be the comorbidities, right? And in fact, we find that as an example, one of the things that men in the early, certainly one of the things related to masculinity, I should say, in much of the world, is the likelihood of smoking. So as an example, here in China, from the beginning, back in 2010, there was a study done, and they found that the prevalence of ever smoking among men and women was highly different. In fact, 64% of Chinese men had ever smoked compared to 3% of women. Now, what does that have to do with masculinity? Well, we know that, in fact, in countries where gender is more equal, women tend to smoke more. Smoking itself is a sign of empowerment and strength, which is often then aligned with, or I should say, the opposite of being weak and demure, and which are often associated with being feminine. So we find that in countries where you have women who are more empowered and have higher levels of economic freedom, you also see higher rates of smoking. And at this time in China, back in 2010, we saw that, in fact, where there is a lot of gender inequality, men were smoking a lot more, women a lot less, and as a result, men have more comorbidities related to lung dysfunction and respiratory illness. We also see with, when we're talking about masculinity, things as silly as men are less likely to wear face masks because somehow it's a sign of weakness. I was actually speaking to a friend recently who went into a Home Depot and they got teased. He was a man, was wearing a face mask and was teased by a bunch of the guys in Home Depot because he wasn't being masculine enough for wearing his face mask. And we see this at all levels of our population, right? That somehow men are refusing to take these safety precautions because it's not manly to do so and they don't need to do so. We also are seeing this when it comes to hand washing. In many parts of the world, men are refusing to wash their hands because they don't feel it's necessary and they never have. We also saw this in the early stages of coronavirus in different parts of the world where men weren't wearing the protective gear and they were out on the front lines and they felt that they were immune to what was going on. So this is all wrapped up in what does it mean to be masculine, strong, powerful, immune to disease, and and it's having effects. But it's not just about mortality. And in fact, often we say that when you're talking about gender, when you're talking about inequality and gender inequality, women are certainly more impacted than men in general. And though gender norms certainly have an influence on men, as we've just seen, when we're talking about inequalities, women and girls and gender minorities are the ones who are most marginalized. And so, in fact, that is true. We're seeing this. So direct effects of COVID on women's health are many. And this doesn't necessarily have to do with just mortality, right? So globally, women make up 70% of health and social service workers. This is also a gender norm. Women across the world are much more likely to be in positions of care and are much less likely to be, or I should say, more likely to be in positions related to nursing, social work, services that tend to pay less, but are more about taking care of people and being on the front line. As a result of that, women are being exposed more and having to deal with those repercussions. There are also a lot of sexual and reproductive health issues as it relates to COVID. So women aren't able to go to the gynecologist or doctor to deal with their sexual and reproductive health for fear of contracting COVID. We're also seeing a lot of menstrual issues in different parts of the world where women and girls are unable to, for example, get menstrual hygiene products because they're unable to go to school and or they're unable to go to the doctor because of fear of contracting COVID and having impacts as a result of that. They also, in parts of the world, women, because of decision-making power or lack thereof, can't go to health services even if they want to without their husbands or partners or a male family member. And certainly as females are potentially not as available or sick or for whatever reason, women aren't able to obtain health services from male service providers that are there. People are also trapped at home with their abusers, and often those people are women and children. And we're seeing that as a major influence of COVID on what's going on right now. And then obviously something as simple as when you're a frontline worker and you're wearing all that PPE, we're seeing a lot of reports of women literally not drinking water and taking caffeine pills and different, doing different remedies to just not be able to go to the bathroom all day because for fear of having to take all their PPE off and put themselves at risk for COVID just to go to the bathroom. So these are some of the direct effects on women's health, but we're also seeing indirect effects. And again, this is a bit of a global focus, but women in general, whether globally or here in the US, are being hit a lot harder by the economic fallout because women tend to be disproportionately in insecure labor. So whether that be service industry or not, something along those lines. And so, and that of course is related also to expectations around women's ability to work, values around whether or not women should be working. And so because of these things, women are placed in a position from the very beginning where they're being hit harder as a result of COVID. We're also in many countries seeing increased child early and forced marriage. So in a lot of countries, early marriage is a remedy for security, for stability, especially in countries where families are very poor. Being able to marry your daughter off to an older man allows for income for that family, and also security, knowing that your child is going to be taken care of, supposedly. And so not only is this an issue normally, but because a lot of girls aren't able to go to school, which is often a protective factor for early marriage. In other words, if they finish school, they're much less likely to get married early. And also there aren't economic opportunities out there that women can have as an alternative to marriage. So we're seeing a spike in early and forced marriage. We're also seeing, and we've learned this through other big outbreaks like Ebola, for example, that essential resources are being diverted away from women's services, specifically sexual and reproductive health services, to COVID. And as a result, we're seeing increases in maternal mortality and morbidity. So I do a lot of work in Uganda, and I recently got a report that there was a woman who couldn't get a ride to the hospital. She was in labor, she was 1.5 miles away, and she died on the side of the road because she quite literally couldn't get to the hospital because they had stopped transportation, and the hospital was focused on dealing with COVID, and as a result, she died. And so this is something we're seeing a lot of, and likely will see a lot of once more data comes out. Likewise, during this crisis, as I had said before, people are stuck at home, and certainly with their abusers, as tensions rise, people become more stressed, violence elevates. But it's not just what's happening in home, we're also seeing it happening outside the home. So as people become desperate to feed their families and to be able to live day to day, we're seeing a lot of gender-based violence and sexual exploitation. And we're seeing this mostly among women, girls, and gender minorities. We also have been seeing female genital cutting. For those of you who don't know what this is, in many countries, it's a rite of passage for a girl to become a woman. It's a circumcision or a mutilation of the clitoris. And where before it was being done within the community, now we're seeing people actually going home to home and doing these practices within the home, making it easier for women to be cut and or girls to be cut, but also making it harder to deal with the repercussions related to infection and mortality. And then finally, something as I don't want to say silly, but as a lot lighter than the female genital cutting is we're just seeing stigmas related to misconceptions around COVID that could have bigger impacts. So for example, one of the lessons we learned with Ebola was that when women, when I should say family members died, often the women of the household were stigmatized because they were seen as not keeping the home clean. And that is why their family member died from Ebola. And so we're starting to see some of that also with COVID. Some of the work I do in Malawi, a lot of residents there feel that COVID is not a virus. In fact, it's the devil, and it needs to be, eradicated. And if women and men aren't praying enough, aren't working hard enough to eradicate this evil, then that's why it exists within the household. So there's a lot around that and a lot of implications. Once a woman is stigmatized from her home, that could lead to anything from short-term implications to actual isolation from the community. And then we have stuff that are going on, that's going on here in the United States when we're talking about how this pandemic is affecting us, not just in terms of morbidity and mortality, but also our own stress levels, mental health, ability to take care of ourselves, and of course, economic stability. And we've done a lot of work in this country and around the world to start to bring women and men to a level playing field, and start to improve the equality across the genders. We have a long way to go, but there are various notions here of whether or not what's going on right now in the United States is just a reflection of the gender inequity that we know exists within our households, or whether there's actually potential to be pushing that gender needle a little forward. So, for example, based on a survey of 3,400 people done by the Fiscal Studies in UCL, University College London, and I just want to say that this survey was done between heterosexual couples, male-female couples. But based on that, we know that mothers are more likely than fathers to have left their paid work since February. And among those who are still doing paid work, mothers seem to have a bigger proportional reduction of hours of work than fathers. And then also, mothers are more likely than fathers to be spending their work hours trying to take care of her children. And so, in fact, we're finding that mothers are looking after their kids almost 2.5 hours more than fathers. And I think it was actually around 10.5 hours a day. And they're doing almost 2 hours more of housework than fathers. That said, fathers seem to also be increasing the time that they're spending on housework and childcare. So there's some hope there, and hopefully that continues to happen. So there's a lot more I could say about this study, but I'm just aware of time, and I want to go on to some take-home lessons and what we can do about it. But the point being is that though we are continuing to see these gender differences, hopefully there's also some good that's coming out of it. So what are the take-home lessons here? Disease outbreaks affect women and men and gender minorities differently. And obviously, as I said before, when you start to have these intersecting identities of race, age, sexuality, class, those differences and those impacts are only amplified. Also, we know that across the board, provision of health services are being taken away from other major things in order to actually start focusing on COVID. And for women and girls, a lot of those services are related to sexual and reproductive health. Also, we see that during times of crisis, we know that women and girls and gender minorities that are at higher risk of intimate partner violence and other forms of domestic violence and sexual exploitation. And sure enough, we are seeing that. We're having anecdotal evidence of people going into pharmacies asking for help or reaching out. And when, in countries where those resources aren't available, it's quite dire for those women and girls. We also know a huge take-home lesson is if we don't act now, what's happening now will actually set us back further. If women can't get their jobs as quickly or as readily as men can, if young girls continue to be married off young and push back the progress that we've been making in decreasing early marriage, if violence continues to increase, where before we were working on decreasing violence, if all of these things continue, it could be that some of the progress we've made over the past few decades may not only be stifled, but could actually be pushed back. And so we really need to be clear about that fallout and how it's going to affect us down the road. So what do we do about it? a lot of what I do in my own practice is helping governments and nonprofits and donor organizations think through how to actually integrate gender into their health and development responses. And so we need to be thinking about how these gender norms, not just sex, but how gender norms, what is expected of us, what are our values around what it is to be male and masculine, female and feminine, how do those things influence our planning and implementation of some of these COVID responses. We also need to ensure that relief funds that we're giving here within the United States and abroad, that they are actually getting to women and that they're getting to them without conditions. In the workforce, we need to be thinking about who's doing childcare, who's being paid for that work, how can we increase paid leave, and how do we continue to prioritize health and safety, knowing the gender norms that are involved there. We need to be thinking about money and whether or not it should be taken away from essential programs. And perhaps more importantly, we should be thinking about what is essential, right? Is our security essential? Is our policing essential? Sorry, I had to get that one in there. Is our, what is it that is essential? And so we need to be thinking about how to distribute our funds. Also, this could be a great opportunity to think about gender-based violence in a new way and actually reframe it as a pandemic in itself. We know it's a huge issue. We know it's pervasive across our country and our world, and we need to be thinking about it as a pandemic in itself. And then finally, to do any of this work, we need to be able to collect data and respond in a way that includes data that's disaggregated by sex and age and gender and pregnancy status. And we need to have women and gender minorities at the table as we're thinking about these processes and ways to move forward. Because obviously they're the ones who are being most affected long term. So that is it. And I think that's just on time, right?
That's fabulous. Thank you.
So if anyone has questions, I'm excited to answer them.
Great. Dr. Levy, thank you so much for the talk and for all the information. I want to lead off with a comment from Sarah, who just wanted to say thank you for your careful language and inclusion of trans individuals as you're considering gender. So thank you for that. And I guess pivoting to questions, Portia is wondering, she's been observing numbers from sub-Saharan Africa, and that case fatality rates are very low according to the data seen, and just curious if that is something that you know anything about. Understanding you don't know everything about everything.
Yeah, and sub-Saharan Africa is a large region. So, it's a tough one because a few things on that. There was a great quote from a woman at the UN who said, here in the global north, it's a public health issue first and an economic crisis second. In the global south, it's an economic crisis, excuse me, the other way around, an economic crisis and then a public health, it's a public health crisis first and an economic crisis second. And the truth is, in sub-Saharan Africa, there are so many other issues to be dealing with in addition to COVID. Things like malaria and, maternal mortality itself and you name it, and poverty. And so I think that it's not that COVID isn't killing people, it's that there are many other things that are killing people. And I don't think that there's the surveillance system and the data collection and a lot of really focus in the same way as the global north as going on. So I just don't think we know the numbers, to be honest. There's a lot of comorbidity, let's put it that way. I don't know if that answered the question.
Jessica, I have a follow-up question as well.
Yeah.
Can you speak to what is known about the impact of COVID-19 on trans or non-binary people?
Well, certainly like with, I don't know the data, I don't know the numbers, but certainly like with most health impacts, the trans and non-binary communities are being highly affected. And in fact, you know, again, we talk about these direct impacts versus indirect impacts. And it's one thing to actually be exposed to COVID and get sick from it and or die from it. It's another to be impacted by it indirectly. So for example, in many, in the trans and non-binary community, you have people who don't have stable housing, who may not have a place to actually quarantine in or social distance in. You have food insecurity there. And the stability isn't such that makes going through this process as easy as it is for other groups. So, so whether or not the outcomes are, I don't know the data in terms of the actual morbidity and mortality rates, but even that aside, the social and economic fallout from this for the trans and non-binary community is horrific right now.
So you had mentioned that it was important that relief funding around COVID be provided to women and gender minorities on an equitable basis and without restriction. When you said that, was there anything in particular regarding to restrictions that you're concerned about?
Sure. So in a lot of, when we talk about international aid, whether it be from a place like the Gates Foundation or the United States Agency for International Development or countries abroad, often when you give, so you'll hear with women, for example, you'll have, you have what are called conditional cash transfers, or aid that comes with conditions, which may involve, for example, going to school for so long, or paying a percentage of it back, or using it on certain things that fulfill the agenda of the giver, right? That fulfill the ideals and what the giver feels will make them healthy and well. But the truth is through this pandemic, there's so much going on that underlies the health and well-being of our populations that it's not really for the giver to say, I think you need school, or I think you need this, or right? That in fact, believe it or not, people often know what they need. And so I think that part of when I say unconditional transfers is to say we're in a really unique situation. When we go to different countries and we say you should be social distancing or you should be quarantining. I mean, half the people I work with live with 20 people in, you know, a room that is the size of my kitchen, right? And so that's a bit of an exaggeration, but that's what it feels like sometimes to them, I'm sure. And the truth is that those things can't be done, right? Because the family structure is different, how you live is different, the ways that you interact, going to the market, who goes to the market, how big is the market, all these things are constructs and ideas that many of us who are doing this work don't understand because we don't live it. And so so that's what I mean by unconditional, is allowing for that money to be given without restraints or constraints.
I have a follow-up question from Portia. It may be in reference to sub-Saharan Africa, but I'm not quite sure. Do you think global response to COVID-19 by the US would have a direct impact on the infection rate for women and girls?
Well, do I think it'll have a direct impact on women and girls?
Yeah, on a direct impact on the infection rate for women and girls.
Yeah. You know, it's hard because I think that the type of work that there certainly needs to be the Band-Aid work of having the PPE material sent and testing and the kits and the what are they called,
Respirators.
Yeah, the respirators. But really, in many parts of the world, we've got to be thinking further upstream. We need to be thinking about what some of these barriers that are related to economic stability, education, power within the household and the community and in different institutions. What are some of the policies and laws around, that promulgate gender inequality and gender inequity? And so I think that the United States, there are some efforts that are focused on these things, that continue to be focused on these things even in the face of COVID. And hopefully those efforts will help thwart some of the longer term impacts. But I mean, none of it is enough. So I don't have a ton of confidence in what our government in particular can do. I have more confidence in organizations that work with community-based organizations, that work more locally, that get on the ground and actually do some of this more grassroots programming and policy making. It's all helpful, but I don't rely just on our government, that is for sure, especially now.
So we have several people just saying thank you for sharing and beginning this conversation and the information you're providing. At the beginning, you had mentioned that estrogen is protective for immune function and that testosterone can actually suppress immunity. Questioner is curious, to what extent do we know whether this accounts for differences in life expectancy versus environmental or behavioral factors? Is that something that has been studied that you're aware of?
This isn't my area of expertise, so I can't really answer that, but it is true that across the globe, men die earlier than women. And so I don't know the answer to that question. I can look for some resources, and if that questioner would like to email me directly, I'm happy to send them more resources. It's an interesting question. There are also a lot of gender norms that are related to early death among men, related to risk-taking behavior, being exposed to different environmental hazards, et cetera, et cetera. So, but it's a good question.
So is it clear to you, based on the early economic data that you're seeing, what you would expect to see happen with the pay gap in light of COVID-19, or is that just way too early to call and too early to see what might be happening?
Yeah, that's another great question. I think it's way too early to see. I mean, I'd like to be hopeful and think that this is just highlighting the data that we're collecting and the stories that we're hearing about the difference between men and women, and how they're kind of weathering this storm, if you will. I would hope that policymakers, both within businesses and our policy in our government, will take note of that and make some changes. But to do that, we need to get people in office who care about these issues. And so this is my plug for making that happen. In order to actually start changing these policies and making the pay gap less of an issue, we need to have policymakers who prioritize it. So get out and vote and get more women in office, gender minorities in office, and men who really care about these issues.
And as a follow-up, I would love to ask you if there are particular policies that you think are most important to this issue right now?
Well, that's a big question, because are we talking United States or globally, or are we talking about health? Are we talking about job security? I mean, my focus is on gender and reproductive health specifically. So obviously for me, policies around reproductive health and having access to reproductive health services is very important and literally life-saving at a time when women aren't able to go to the doctor from things like anything from sexual violence to prenatal care to having an abortion to on and on and on. And in fact, again, for me, based on our experience with things like Ebola, we have seen increases in maternal mortality and unsafe abortions. And so I would like to see policies that just make reproductive health care more accessible for women during this time. Obviously, and that is true across the world. But there are also policies as they relate to paid time off, maternity leave, parental leave. We need to get men more involved in actually taking on the burden of household chores. Yeah, I mean, there's just so much, for sure.
We are nearly at time, and before closing out, I do want to offer you an opportunity to share any closing comments or final remarks with the group.
Yeah, I think I would just say that though this lecture or this conversation is around gender and COVID, what we're seeing happening today in our world with racism is directly influenced by and influences the outcomes that we're seeing that are related to gender. And this is a marathon. It's an ongoing battle, and I think that it would be a real tragedy to see all the work that we've done as it relates to gender take steps back because of the pandemic. And so, I appreciate that a lot of what needs to be done in terms of programming and policy making really does need to take into consideration the gender norms that exist in each context. But you as the viewer, you as our community member, you as the person who, may turn this off and not necessarily, think about gender and health again, should really think about how you yourself are promulgating or promoting or moving within the gender norms within your own household and institutions and businesses. And there's a lot that you can do through modeling, through speaking up, through teaching your children, through having conversations that can really influence some of these harmful norms that are having the impacts we're seeing today.
Well, thank you for that. Thank you so much for today's talk and all the information that you shared. And thank you to my co-host, Lee Koliker, for helping to moderate.
Good to be here.
I appreciate everyone who made time to be with us today. I'm glad to have you with us. I want to make note that in addition to the COVID-19 and race programs that we talked about before Dr. Levy's talk, we are back in our regular spot on Thursday at 12:30 for a program on resiliency and responding to a pandemic through virtual service delivery methods. Our guest speaker is Carl Josahart, who is a Brown School alum, now Chief Operating Officer at Jewish Family Services in Houston. And they've done an amazing job in this pandemic, keeping all of their programs going virtually. So if you are at all in that role of a social service provider needing to make a pivot, they have a great case study and a process to share. So that will be a great talk. And with that, again, thank you for being here. We wish you healthy and safe and hope to see you back on Open Classroom very soon. Take care.
Thank you.
Bye.